Good evening, everyone, and welcome to our Woo You event in the trenches, managing GA in traditional optometry practices with three incredible practitioners, Dr. Koetting, Dr. Dierker, and Dr. Kramer. Oh, next slide.
Sorry.
I don't know who's And I am going to be your host tonight. My name is Dr. Stephanie Wu. So now it's my pleasure to introduce our three faculty members for tonight. So first we have Dr. Dierker, who is the Director of Optometric Services at Eye Surgeons of Indiana and an adjunct faculty member at Indiana University School of Optometry. He has special interests in ocular surface disease and retinal disorders, and he has developed a dedicated dry eye clinic within his practice. I know he's very well known for dry eye, and he helps colleagues across the country in this area. He's the creator of Dry Eye Bootcamp, and he is the co-founder of Eyes on Dry Eye. Welcome, Dr. Dierker. And here are his disclosures. Next, we have Dr. Koetting, who practices at an MD-OD practice at the Hines site in Denver, Colorado. Her primary focus is in anterior segment and ocular surface disease, neurooptometry, and perioperative care. She's a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, an active member of the AOA, and she has served both local and state officers at AOA, and she was named Young Optometrist of the Year in 2019 by the state of Virginia. She lectures nationally, locally, and internationally at conferences, and she has written for numerous publications. Next. And here's her disclosures. And last but not least, you're seeing her on a different end. Dr. Kramer is often a moderator for Woo You, but it's very exciting to actually hear from her because everybody always loves to hear from her. Dr. Kramer is a residency trained optometrist in Miami, Florida. She specializes in ocular surface disease and regular and specialty contact lens fitting. She had her Doctor of Optometry degree from University of Montreal in 2012. And during her fourth year, she completed her internship in ocular disease at the Eye Centers of South Florida and went on to complete her residency at the Miami VA Medical Center. She was also trained at the Bascom Palmer Eye Institute, which is the nation's top eye hospital. After her residency, she became a fellow of the Scleral Lens Society. She's a board member of the Scleral Lens Society and an expert in specialty lenses. And here are her financial disclosures. So now I will turn it over to you three amazing doctors. I'm really excited about this event because I feel like so many doctors get scared of GA, especially people like me that don't see it a lot. And so I think a lot of doctors are going to learn a ton of pearls from you guys, just being in the trenches and seeing these patients in real life. And welcome to Woo You.
Thank you so much. Dr. Wu, I'm one of those doctors who gets scared by GA because, as you know from my introduction, I do specialize in anterior segment disease and contact lenses, ocular surface disease. So this is definitely something that intimidates me, but it is important. Geographic atrophy is an advanced form of age-related macular degeneration, and globally, AMD is among the leading causes of blindness in adults aged 50 or older. GA is progressive, advanced form of dry eye AMD characterized by loss of the RPE photoreceptors and choriocapillaris, leading to significant irreversible loss of visual function. So it affects more than 5 million people worldwide. So it's definitely extremely significant. 973,000 people in the US have GA and more than one eye or more. And after age 50, the prevalence of GA approximately quadruples every 10 years. GA accounts for about 20% of all legal blindness attributed to AMD. So do you guys feel like these numbers represent what you see in your practice and when you see primary care patients?
So that's a really good question. And I would say that this seems a lot more than I've seen. And at this point, I'm not necessarily really taking a lot of time to dilate my patients, but I do have a fair amount of my patients who are referred over from the retinal clinic, as well as even talk about 2 years ago when I was doing more primary care. This seems like a lot. It seems like a lot more to me than I feel like I'm seeing, but I don't doubt it.
What about you, Dr. Dierker?
Yeah, so I think that you got to put this in context with other disease processes that we're seeing. So if you are managing glaucoma, which I would imagine the majority of our attendees are, there's probably about 4 million people in the US with glaucoma. So for every glaucoma patient you potentially have, for every 4 glaucoma, you potentially have 1 GA patient in your practice. And if you are seeing older patients, 70, 80, 90-year-old patients, that prevalence goes way up. So at different points in my career, I would have days where I would see multiple GA patients. Kind of where my practice focus is at now, I see a couple a week. So I think this is something that everybody sees. And hopefully with what we go through tonight, you're going to have some pearls of probably we're missing it a little bit and just calling it dry AMD or even early AMD, when really these patients have advanced disease. So I think that number is correct when we actually get down to what are we calling GA, and that definition we'll go through tonight.
That's a good point.
Next slide. So the etiology of GA involves a complex interplay between age, environmental factors, and genetics. So some of the demographic and environmental factors would be age, smoking, diet, high alcohol intake, high body mass index, comorbidities, and genetics account for about 70% of the risk of AMD. Genetic factors, these are genes including CFH, C3, and ARMS2, HTRA1, which have all been associated with GA and may contribute to drusen formation, oxidation of phospholipids, immune response, and inflammation. Next slide. So with aging, the RP is exposed to oxidative stress caused by retinal metabolic demands, photooxidation, environmental stressors. And you can see these 2 images here. The one on the left is the healthy retina. The one on the right is the early or intermediate AMD, where you see the drusen and the macrophage. Damage caused by these stressors can accumulate, resulting in formation of extracellular drusen. And so these are intrinsic and extrinsic factors. Excessive drusen accumulation may trigger inflammation via multiple pathways, like the complement cascade, leading to photoreceptor, RPE, and choriocapillaris cell death. Loss of photoreceptors, RPE, and choriocapillaris results in sharply defined atrophic lesions, which are characteristic of GA. Next slide. So this is really important. Vision loss in GA can progress quickly and can have profound impacts. If you just look at this graph here, we see that 16% progress to blindness in the better seeing eye with a median time progression of 6.2 years. 67% progress to vision loss that left them ineligible to drive. So this is huge and significant because it will affect their lifestyle and daily activities. And that was a median time to progression of 1.6 years. And 40% lost more than 10 letters equal to or more than 10 letters in the worst seeing eye, with a median time to progression of 2.4 years. This seems like a very quick progression. In your experience, when you see patients, do you feel like it progresses this quickly?
I think we're catching it kind of late. So when we see it, it's like, oh, that's definitely GA, the horse is already out of the barn. So I think that as we get more sophisticated with our imaging techniques, we'll find that it's actually probably a little bit slower. But I think both optometry and ophthalmology, we're catching it late. So then you say, oh my gosh, it's already so close to the fovea. And within a year or two, then it hits the fovea. These patients have significant loss of function well before it gets to the fovea. So, kind of a runaround answer to your question is, I think that this is correct with how we are managing this now. My hope is that as we get better at this and as we have therapeutics that are better, we're going to catch it earlier. And it's really going to be more of like a 5 to 10 year process, not a 1 to 2 year process.
Yeah, the importance of early detection, right? So.
Yeah. Absolutely, which is what we're going to talk about, right?
Next slide. So how do we know when to refer? And, this is, I think, probably arguably the most important thing, at least for me, because, I really don't manage retina, as you know. And so when do we refer? And, early AMD and intermediate AMD, and it's important to understand the difference. Early AMD is when you have medium drusen, which is 63, greater than 63 microns, but less than or equal to 125 microns. No AMD pigmentary abnormalities, but intermediate AMD does have AMD pigmentary abnormalities and or numerous medium-sized drusen or one large drusen, which is bigger than 125 microns. And basically, we see that in these intermediate AMD cases, the 10-year risk of progression is for the highest risk category was 53.9%. And also for neovascular AMD, the 10-year risk of progression for highest risk category was 47.6%. So this is where the referral is required. And I think that's the key point, is when we dilate patients and we see and we're able to understand the difference between early AMD and intermediate AMD and understand their risk of progression. And that was really the key for me in understanding, GA. What about for you guys?
So I think that I'm interested to see what Cecilia has to say too, is I think when we look at now that we have a couple of therapeutic options for GA, we really need to be referring those patients. And that's a new conversation. We've not had that outside of referring people for clinical trials in the last, couple decades. So I think that the absolute must for any optometrist is if you have GA, especially GA that's progressing and a patient that's motivated, you need to refer that patient. And then obviously if a patient has active wet, we need to refer. But I think that you start moving to the left, and there's going to be a lot of variation. It is not wrong to refer a patient with early AMD for multiple reasons, depending on what your focus of your practice is. If you don't have an OCT, all but the earliest stages of AMD, you should be referring. Intermediate, if you're not willing to see a patient 2 to 3 times a year to manage that AMD, you should be referring that patient. So I think depending on your level of confidence and training and expertise and focus of practice, you may refer that patient all the way on the left. I think an absolute must is the 2 on the right. Dr. Koetting, where do you fall on that?
I completely agree. And that's, one of the things is if you don't have fundus autofluorescence, you don't have OCT, depending on where your level is, right, you are absolutely okay to refer at any level, but you have to refer the ones to the right. But it is not wrong to refer the ones that are earlier. And at the end of the day, we're there to take care of our patients. And if we err on the side of caution and refer them earlier, and then we get feedback from our retina specialist who says, yeah, thanks, but no, they're fine right now, right? It's also a learning moment for us to say, okay, so next time I see that, maybe we're not there, or maybe I still don't feel comfortable with it and I'm going to refer it. And I've gotten things back from retina that said, hey, you were right. And sometimes it says, hey, you were wrong. And you know what? I'm okay with that.
You know what? It's never wrong to refer. And I'm definitely on the way left in this, slide. And I don't manage retina at all. And so if I see early AMD, I refer. I just want them to meet a retina specialist. And even if it's early and they have to come back annually and they're not being followed up more than that, I just want them to meet some retina specialist that they feel comfortable with.
Your new friend.
Yeah, I'm going to disagree just a little bit there, Dr. Kramer. And this is a really good part of this discussion is the 2 on the right, GA and neovascular AMD, need to go to retina specialist or a general ophthalmologist if that's what you have in your area, someone that can provide therapy. I get referrals every week from optometrists for early to intermediate.
Lateral, yes.
So I think that a lateral referral to someone that has a focus, just like we have dry eye specialists, contact lens specialists, low vision, referring to an optometrist for early to intermediate is absolutely appropriate. And I've had hundreds, if not 1,000 or more referrals for AMD from optometrists to me. And then if they need to go on to retina, that happens. But we know that there are so many millions of patients in that early to intermediate that we cannot rely on the retina specialists alone to manage those patients. That is why we're having this discussion tonight, to have the confidence in our colleagues, if not ourselves, to manage that early to intermediate patient.
Correct. So
Great.
optometry retina specialists. So it's important to identify patients at risk of developing and progressing GA. This helps in effective patient management, but facilitates provision of appropriate education and enables offering treatment recommendations. So basically what we're trying to do is we're trying to slow down the risk of progression, and we're trying to preserve their vision for an extended period of time. Next slide. But again, this is not something I personally do in my practice, but just because I manage the front of the eye doesn't mean I should forget about the back. And I think that is a key point. I like to dilate my patients and check and make sure that I'm not neglecting a retinal exam. And if they don't want to be dilated, if they're turning it down, they just came in for that specific reason, for their contact lenses or for dry eye treatment, at that point, I do send them laterally to someone or, to an ophthalmologist who will dilate them, because it's very important to remind patients that they need to have their retinas checked. And again, early detection is key in these cases, as Dr. Dierker said, Dr. Koetting as well. And so again, important not to not neglect the back of the eye just because we're focused on the front, for the contact lens fitters in this audience.
You heard it here, guys. Dr. Kramer acknowledged that the back of the eye is important. Perfect. So I'm going to actually jump in here and I'm going to start taking us through some of the diagnostic testing that, some of these things we have, some of these things we may not have been looking at, especially with GA, because there's not been a lot to do with it in the past. And now we've got some new treatments that have emerged, as well as we've got others that are coming down the pipeline. And I think it's really important for us to look at this. And for those of us who have the machines, maybe get a little bit in there, get some lateral referrals from our friends. For those of us who maybe don't have the technology in our office, to understand what they're looking at and really how much of this we can understand and monitor as optometrists ourselves. And so as Elise, Dr. Kramer already mentioned, we're looking at the progression, right? From our early to our intermediate, and then from intermediate, they may go towards GA or advanced AMD. And really, historically, we've really been focused more on that neovascular and looking for signs of neovascular and macular edema, right? But we also need to be paying more attention now to the GA. And these atrophic lesions, we tend to see a lot of changes within the growth of the lesions themselves prior to us getting to the point where we're noticing visual loss and irreversible visual loss. And so you see this kind of depiction here of typical progression with geographic atrophy and the lesion itself, starting more in the peripheral area around the fovea and around the macula, maybe causing some low light vision disturbances, and then losing more of the peripheral vision, moving into patches of central vision, and then actual true central vision loss. And it takes a median of 2.5 years from the first appearance of foveal GA to progressing faster, towards the loss of that central vision. And so Dr. Dierker already mentioned this. We looked at what are some of the ways to measure it and how quickly we see these changes. Well, talking about central VA is not the whole story. That is not the only thing that we should be measuring and looking at these patients. And sometimes it's just easier to honestly look at some of the actual physical testing that we're going to talk about. And as I mentioned, BCVA definitely does not capture everything here. If we look at this depiction, we see that this patient, visit number 1, look at those lesions, and the vision is 73. We kind of count that down to probably about 20/30, 20/40. And then we start to see that these lesions are growing, but the difference between year 1 and 18 months, so 6 months later, the visual acuity hasn't decreased, but there has been a significant increase in size of the lesion itself. So one thing that we all have, right? Well, almost all of us, right? If nothing else, we at least can dilate and look back there. But fundus photos, a lot more of us have the ability to capture fundus photos at this point. And this is actually a patient of mine from my previous clinic. And this was actually prior to us having any treatment for these patients. So guess what? This was me monitoring because I didn't have any treatment to offer them. A lot of times though, in a patient where they have this amount of geographic atrophy, I get that kind of like, you know what, I think you should meet a retina specialist, going back to what do we do with these patients. And so oftentimes when I'm looking at something like this, before we had treatments, I would still send it just to make sure that I had the blessing of my retina specialist to say, yeah, just continue to watch. There's not anything we can do. So with color fundus photography, things that we're actually looking for, we want to look for visible choroidal vasculature. So like in my patient, you could see that there was a fairly significant amount of atrophy, and you could start to see some of that choroidal blood vessels through the areas where we lost the pigmentation. The other thing is to look for areas of hypopigmentation and more sharply demarcated borders. This can kind of help us understand where it is and really map out how large are those lesions. And then year by year, maybe be able to monitor, am I seeing these getting larger? Now, to be honest, at this point, that patient on that right side, that's going to need to go to, retina anyway. You see this at this point, I'm going to send this to retina. What about you two? Would you send that patient on the right to retina at this point?
Definitely, I would. This is not something that, I mean, I know the risk of progression, right? And I know I would definitely want this looked at by a retina specialist.
I will say maybe, and when we get to my part of the talk, we'll kind of have a better explanation for that. I think you have to have a conversation with the patient.
Absolutely.
And you have to have a relationship, and the answer is maybe. And I'm interested to hear your feedback once I get through my part of the talk.
Okay. We're all learning here. That's why we're here, right? But you know, the idea is going back to the staging. If somebody's already at this point where they're showing signs of geographic atrophy, they're technically advanced macular degeneration. And that's historically where we start having those conversations and or referring out. With fundus autofluorescence. So this is really more of where we start to get a better idea of what's going on. Okay. And many more of us have the ability to use fundus autofluorescence in our office, especially with some of the settings that are on our fundus photography now. And with this, we can actually look for areas where there is, so if we see a dark area in this, we see that that's hyperfluorescence. So that's actually areas of increased lipofuscin concentration. And then that's the hyper, and then hypo is where the RPE cells have already atrophied or absent. The other thing to look at is one of the things that we can gain from this is if you're seeing hyperfluorescence and it typically is bordering the area, that means it's still progressing. And there's some data out there and studies that are saying that actually where you see more hyperfluorescence is more than likely where you're going to see it progress in that direction the next time you take a photo. So that's a good thing to be looking for there as well. So again, looking at the hypoautofluorescence corresponding to the GA lesions, looking for the depigmentation hypoautofluorescent regions that correspond to the actual RPE atrophy, and then looking for the hyperautofluorescence surrounding the regions representing areas, like I said, of ongoing RPE cell dysfunction, meaning it is progressing. What are some of the risk factors that we are also looking at on these tests, or specifically on FAF, that put a patient at a greater risk of progression? So this may be, say, hey, we looked at that fundus photo, right, that I showed. And we go, okay, well, maybe we don't send it, just like Dr. Dierker was saying, right? But then we do the autofluorescence and we start to see things that tell us that they have a greater progression rate. Maybe that's going to be our kind of our hang up for, nope, now I'm going to refer it, right? So looking for multifocality. So if there is multifocality within that, that area of atrophy, on the FAF, so you can see the difference. The top is a unifocal, meaning it's more of a central area of RPE. It's just kind of uniform, versus multifocal, where we get these kind of pockets almost, right? And that means that they have a higher risk of progression. Another risk that we're looking at is looking for an abnormal pattern, something that's more banded or diffuse FAF phenotypes. And then also looking for non-foveal location and progression towards the periphery. So foveal, remember, we also talked about where does it start? It tends to start perifoveal and move into the center. So that's kind of going along with this as well. Now, the other thing that we have in our office that's kind of cool to use is an OCT. Guess what? That's a pretty common thing we also have, right? And if not, guess what? You got to phone a friend. All of us know someone who has one. It is okay for lateral referrals. And here, what we're looking for is we're looking for lesions being identified by loss of that RPE and photoreceptor layers. So we can see on that bottom image that we've got the hypertransmission below. So we've got actually, I can use my little arrow right here. So we've got hypertransmission here underneath this area where we've lost the RPE and photoreceptors, as well as we've got the absence of the external limiting membrane there. Now, do you have to be able to describe it just like I did? No, you do not. I can also read off a slide, which is the good part, right? But if you can look at that and go, that's not normal, I don't like that, we can move on from there, right? Other things that are predictors on OCT that may mean there's a risk for progression or that they are progressing. Looking for reticular pseudodrusen. These are drusenoid deposits. So we look here in this little box, right? And it comes out and we see these little projections almost of RPE, right? So these are drusenoid deposits that are coming up above that RPE. They may actually represent a risk factor for the development of late AMD, meaning we're going to move into that late phase AMD or more progressed, right? The other thing that we want to look at is sinking in of that INL and OPL. So we see here where we've got this hyporeflective wedge that it's pointing to. That is the retinal layer. The retinal layer is actually starting to sink towards the RPE in that area of the outer atrophy. So it's sinking in to fill in where that RPE is now missing. And that will mean that they're at a higher risk to progress to geographic atrophy. The other thing you can look at is a hyperreflective foci. These are these little spots that we see here. And there are discrete punctate lesions that are equal or greater in reflectivity than that RPE. So remember right here, we've got our RPE, but we've almost kind of got little drusenoids coming up there, right? Almost kind of like that reticular pseudodrusen, but we see these little specific spots, these punctate areas. And that is what that hyperreflective foci are. And that's another indicator that there's a higher progression likely to happen from early to advanced geographic atrophy. Beyond here, we can of course look at our macular raster. This is actually, this is more of just a food for thought for you all, okay? This was a patient who was seen, and the patient was judged as having, by an optometrist, having stage 4 dry AMD. But then it was sent to the retina specialist, and their assessment was actually, nope, that's neovascular AMD with active CNV. And that's why sometimes with these where it's like, you know what, we're already into this more aggressive or late stage or advanced AMD or geographic atrophy, it's not wrong to go ahead and send it, because the way that we may interpret it might be a little bit different than the retina. And I'd rather err on the side of caution and get this note back saying, thank you for referring, but you were wrong, but you got them to the right place. Last few things here, these are things that are coming up. Most of us don't have this or aren't doing this, but it's near infrared reflectance, or NIR. This is fundus images that are actually acquired simultaneously with OCT, and then it allows for overlay of the photo in corresponding area to the OCT. So it gives us a little bit more information. The other thing is fluorescein angiography. I don't know, honestly, a lot of ophthalmologists and retina specialists that are doing this as much either. I find they're moving away from this quite a bit with the advancement specifically of being able to do this, which is OCT angiography. And this is, gone leaps and bounds in just the last 5 years as far as the just sheer detail that you get out of this. Now, I'm not doing this. I've gotten to see a few of these. Obviously, I've got a nice little picture up here of them, but this is a lot of where the retina specialists and or optometrists who are specializing in retina or within a retina clinic, they're really looking at these versus really looking at those more traditional OCT, fluorescein angiographies that I got to do when I was in residency. Last little thing here, can't forget about at-home monitoring. Our fancy grid paper that we give our patients. Yeah, I feel really high tech when I bust this out. To be honest, I don't use this very much anymore. I have really moved over, and you guys can give me your thoughts on this and what you're doing, but I've really moved over towards doing these other options as far as at-home monitoring. There is 4C Home, which is a device that's into patients' homes. I've had really good ability to monitor my patients with that, as well as there's a number of apps for phones now that are just a little bit more helpful in getting information, as well as then passing the information on to the doctor. So I've liked those. What have you guys been doing? Still busting out the fancy graph paper?
I actually like the Amsler grid. I think it's cool. You can put it anywhere on your fridge. And I just feel like some of these, they might not remember to do it. However, I am moving more toward the phone app. I can't say I've tried any of the fancy home monitoring, but some of the phone apps are cool and definitely maybe more accessible or more realistic for a lot of patients. But I kind of like the Amsler grid, to be honest.
What about you?
I will have a slightly different opinion. So Amsler grid, I think if you don't have anything else, you should probably do it. It's
better than nothing.
Better than nothing, not much better than nothing. Invented before World War II. It kind of does things that fill in the gaps sometimes. So it's going to catch catastrophic changes. I'm a big fan of 4C Home. It's going to be something that's covered by insurance for patients that have intermediate AMD. So those higher risk patients for converting to wet. I prescribe this for a patient. They do home monitoring, takes them a couple minutes. When they have a change in metamorphopsia maps, we get an email that says, hey, your patient has had a change. It's a change that's been repeatable. So it's not just a one-time thing. We bring them in, we do OCT, OCTA, and I have several cases where we've caught wet AMD when they're 20/20 and they're asymptomatic, but they had this metamorphopsia change with a preferential hyperacuity perimetry, which is what 4C Home does. We get them in, we get them treated. So that has been a huge thing for my practice for those intermediate patients. And when you compare that to the Amsler grid, part of the ARIDGE-2 study looked at standard of care, which in an intermediate AMD patient, you should be seeing them every 6 months, and you should probably be doing an OCT every time they come in, and then maybe do an Amsler grid to monitor between visits. They looked at that group in ARIDGE-2, and then they did a group that also added the 4C Home. And they had to stop the study early because the results were so favorable for 4C Home versus standard of care. It was the second time ever in a US ophthalmology trial for retina that they stopped it because of positive efficacy. The only other one was back in the 80s, diabetic retinopathy study. So the data is there to support 4C Home. And if you're seeing intermediate patients, you should definitely be considering this for your practice. And I think these other options here are accessible as well. 4C Home, I think, has the greatest science behind it. So I'm definitely a fan of that.
I would agree. So I have a question too, Damon, because I'm wondering if you in your practice have gotten to use this. What about, so, and I didn't bring this up because this could be an option for an in-office monitoring, would be the RET eval, which, you know, there's some data behind it and showing disturbances of, you know, the ERG and other wavelengths of functionality from the retina itself. Are you guys doing anything with that?
I've not ever done ERG testing. I think there's probably some value in other disease states, glaucoma.
I've done it in diabetic. Yeah, diabetic.
I think less so in AMD simply because our other diagnostics are so good when we look at imaging for these intermediate to advanced. And then when we look at dark adaptation testing for the subclinical to early, I think we've got things pretty well covered that I don't know. Somebody could make a case that ERG provides some additional value to decision-making. I haven't felt the need to bring it into my practice.
Right? Sometimes it's about what do you have, and if there's enough, but I can't say I have enough experience, but that's why I figured I'd see if you did.
Yep.
Perfect. Well, we'll move on into your area.
All right. So we're going to talk about treatment and co-management. Next slide, please. What I found, we kind of put all this together independently and kind of worked through it. But what was interesting and completely unintentional, but I've just realized this, is that all three of us have talked about staging. So if you say, hey, what's an important take-home point from this presentation? It's this slide right here. Early, intermediate, advanced is we have to start using this in our charts. We have to have the appropriate ICD-10 codes. We need to be treating our early patients different than our intermediate, different than our advanced dry. You can't just put dry AMD anymore. There's too many things going on, too many options for therapies now. Dry versus wet isn't good enough anymore. You really need to say early versus intermediate versus advanced. And you'll see this, you can get this in the handout, but I think that's an important take-home point. If you're not doing this now, you need to start doing this, because when we have treatment options now for both GA and neovascular, that's obvious. We're not that far away from having treatment options for intermediate and maybe even early. I think we're going to have that within the next 5 years. So I think we want to have these patients in our chart. So if there is something that comes up, we can actually maybe harvest our charts and figure out who would be a candidate for these therapies. And then you say, well, what can we do about AMD before we get into GA specifically? Well, everything, whether it's, risk prevention, subclinical, early, intermediate, advanced, everything on the left, we should be all talking about with our patients. And I give them a handout. We talk about smoking cessation, green leafy vegetables, omegas in the diet, nutritional supplements, cardiovascular disease, risk factor control, exercise, weight control. All of these things are going to have a positive impact on your patient. Biggest one, smoking for sure. But if you simply make the diagnosis of AMD and tell the patient, I need to see you every year, you're going to call me if you ever have a sudden change in vision. It has been proven in studies that that alone reduces your patient's risk of losing vision. And then you start talking about nutritional supplements and other things, home monitoring. There is a lot we can do as optometrists at this moment in time to have a positive impact, especially for these patients with either risk factors for AMD, early and intermediate disease. Next slide, please. Now we get the big, oh my gosh, what have I done? Complement cascade. I thought I was done with part 1 of boards a long time ago. Hey, it's back. It's back, baby. We're going to talk about complement. Not in detail, but we know that complement, we get this kind of ramping up of the complement system in patients with geographic atrophy. And this is a dysregulation of the complement system. Normally, this is part of our innate immunity that is responsible for removing pathogens and sometimes removing dead cells. And in patients with AMD, they have been shown to have increased levels of activity of the complement system. And you can get into this cascade, this pathway, either through the classical pathway, or the lectin pathway, or the alternative pathway. You don't really need to know any of that other than complement is important in AMD pathogenesis, particularly geographic atrophy. So when you have dysregulation, it leads to excess phagocytosis, inflammation, and cell death. all of these things can potentially lead to increasing lesion growth in patients with geographic atrophy. Next slide, please.
Got stuck, sorry. There we go. Maybe.
So when we look at now our historical treatment options for geographic atrophy, it would be diet, nutrition, smoking cessation, referral for low vision. Now we have 2 different medications that have been approved within the past year, which is why we're having this discussion. Think about all of the attention we've had on identifying Demodex blepharitis in the last couple of years. Or look at the last 5 years looking at neurotrophic keratitis, early detection treatment. Why are we talking about this stuff? We've seen it forever, maybe we missed it. Well, when you have treatments that are now FDA approved for these problems that we've never had a solution for, we really have to understand who these patients are and what we can offer them. Now, within the last year, 2 separate drugs have been approved. Pegcetacoplan or Syfovre was approved in February of 2023. It's a intravitreal injection. Its indication is geographic atrophy secondary to AMD. And its mechanism of action is targeting C3 on that left in the complement cascade. So basically it inhibits that and it slows down this overactive complement system. So it's a complement inhibitor is what we're doing with pegcetacoplan, as well as avacincaptad pegol. Say that 3 times fast. Izervay is approved in August of 2023. Again, GA secondary to AMD. So look at that indication. It's not saying that your patient has to have 20/40 GA or symptomatic GA or multifocal GA, or it says the indication is GA secondary to AMD. That's a very broad indication. That's why we're talking about 1 million people that could potentially be candidates for this therapy. This one works a little bit further downstream. Instead of C3, which we're treating with Syfovre, it's going to target C5 in the complement cascade. Clinical trials to support Izervay have been GATHER1 and GATHER2. In clinical trials for Syfovre were Oaks, Derby, and Gale. And then when we look at the different dosing schedules, Syfovre is intravitreal injection every 1 to 2 months. Izervay is looking at monthly injections for up to 12 months. So every 1 to 2 months, we have therapy with injection therapy that can potentially slow down the progression of geographic atrophy by modifying and inhibiting the complement cascade or the complement pathway. Go ahead and next slide, please, because I think this next slide kind of pulls all of this together, what we're talking about. So if I were to say, what is the most important slide that we're going to see that I'm going to give you today? It's this one. So complement inhibition therapy slows the progression of GA. What does that mean? It does not make your patient's vision any better. It doesn't necessarily prevent your patient's vision from getting worse, but it helps to slow down the progression of the disease. And when you have a progression that over a period of just a couple years can go from I'm not having any problems to I can't drive anymore, we want to identify these patients for potentially therapy. I don't think we have to worry at all about, do I send this patient for Syfovre or Izervay? Are they going to do an injection every month or every other month? As optometrists, we don't even really need to be part of that conversation unless you're in a very unique, specific practice. I think you have to understand that these things exist and that we should be educating our patients about it. And then when we look at, well, if this is so important, well, what is it that we should be looking for? And we've already hit the highlights on this a couple different times with Cecilia and Elise, but these 3 images I think are really important. When we look at patients that we want to consider treating, we want to find the patients that are at the highest risk for losing vision. If we look at lesion size, we know that smaller baseline lesions have slower progression. If their lesions are larger at baseline, they tend to be faster progressing. We know that lesions that are foveal progress slower. Their locations are non-foveal, they progress faster. That is really, really critical because these patients that they may have 20/20 vision, but they could go to not being able to see their granddaughter's softball game in 2 or 3 years. So this non-foveal, multifocal, kind of medium-sized lesion, boy, you got to be looking for that. So looking at lesion size, location, and focality, we know that unifocal lesions progress slower, multifocal progress faster. So larger lesions that are non-foveal, that are multifocal, just looking at your color photographs, looking at your fundus exam, looking at your en-face OCT, or using fundus autofluorescence, that's going to be very helpful to identify those patients. Dr. Kramer, Dr. Koetting, any comments on that? Do you agree that this is kind of putting it all out there on one slide?
No, I think it is. I think this is a really good comprehensive slide.
Totally. I think it's important to understand what is more at risk of progressing. My one question that I had was, you said, it doesn't reverse. So once the damage is done, it's done. It can't be reversed.
Correct.
So it's super important to really catch these early. And you were talking about, like, for example, that non-foveal lesion, it's more like faster progression. So even if they're seeing well and they're asymptomatic, these patients could have a major progression versus those that already have foveal involvement.
So what you just said right there, tweak it slightly, and that's what you tell your patients. And why am I seeing you back in 6 months? Because I'm worried that what I'm seeing could progress, and it can do so fairly quickly. And if I see any sign of progression, I'm going to send you to a retina specialist because we now have some treatments available. And I think if you see these lesions now, you don't have to wait for them to progress. If you see some things that are questionable, maybe see them back in 3 or 4 months and look for any sign of progression. But I think you see those larger lesions, non-foveal, multifocal, boy, that's out the door, because these are patients that can have significant help, whether they have Syfovre or Izervay, and we don't have to make that decision of what they're going to get or how often they're going to get it. We'll talk a little bit more about the patient education as we move forward, but I do want to get into our couple of case examples. So management of all but early stage AMD now requires multimodal imaging. We'll see examples of that. Dr. Koetting did a good job explaining the ins and outs of all of that. But these are the things that I'm using routinely in my practice with OCT and en-face OCT, and then color photographs, as well as fundus autofluorescence. Next slide, please. And then another point to reinforce from what Dr. Koetting said, when you look at the image on the right, the fundus autofluorescence image, I think the best way to think about this and explain it to the patient is like, this is a metabolic map of your retina. And in areas where it's dark or black, there is no metabolic activity, it's dead. And in these areas where it's bright means there's a high amount of metabolic activity. Something's happening there that's eventually going to cause more tissue destruction. So when we see these patients, and just go ahead and advance one, when you see that hyperautofluorescent border, these are patients that retina is on fire. That retina is changing and is at high risk for progressing in the size of their GA lesion. Next slide, please. So I've got 3 case examples, and these are all case examples I've seen within the past year that I have referred for consideration of complement inhibition therapy with injection. So this is a 77-year-old white male, presents for an exam, complaining of blurry vision in both eyes. He had been seen elsewhere and told that he had the start of macular degeneration about a year ago, had cataract surgery about 5 years ago. His best correction was 20/25 OD and OS. So looking at the OCTs, it doesn't look like on the B scans on the upper part of the slide that we have any sort of sign of exudation, but it definitely doesn't look normal. We see drusen, we see some hypertransmission defects, we see some loss of that outer retina, the ellipsoid zone. So I look at that and say, boy, that doesn't look normal at all. The patient certainly has AMD. But then I think if you look at the maps on the bottom and the thickness maps and kind of those deviations, you can see like, boy, that retina is really thin, except for the center part of the retina. Well, that's why their vision is still 20/25. But this patient, you can imagine driving at night. being able to read at efficient speeds, this patient's going to struggle. Next slide, please. So we're going to see the importance of multi-modal imaging is like, okay, well, now it's really obvious. This is the same patient, and that OCT that didn't look all that bad, well, they've got multiple areas of hypoautofluorescent lesions on the FAF with hyperautofluorescent borders. This patient is a very quick referral to retina, not necessarily urgent or emergent. It's a first available referral. But Dr. Koetting, what would you tell a patient like this, what you're seeing and what you're going to do and why you may refer them for possible treatment?
Yeah, I'd say that, hey, I'm seeing we've got some geographic atrophy, which, we can get into what that is, but it's causing damage to a part of your eye that is your detailed vision. And I see some signs that make me concerned that it is going to continue to progress and probably more rapidly. And so I'm going to refer you over to a retina specialist so they can evaluate it. Since they're special at this and I'm not, I'm gonna take what they say, but I would like their opinion. And they may decide to treat you. And I'm gonna let them get into that with you. And the nice part is, depending on the patient, you read the room and how much you want to get into it, because some will go, what's the treatment? And you go, well, it may mean you're going to get injections. Right. And we know sometimes we want to bring that up with certain patients. We have others that we know we will hold that card to our breast and let retina deal with that.
So what I would say is, Mr. Smith, you definitely have macular degeneration, and it's not just early. It's actually what we would call advanced macular degeneration. And you have some areas, and I would pull up some image, probably either color photo or FAF, and say, you've got these areas here in your retina where the tissue is missing. We call that atrophy. And that is why you're having blurry vision, because your retina is not healthy at all. This is something that's developed over years and years. We don't have a cure for this, but we can slow things down and reduce the risk of you having more significant vision loss with therapy. This is something that we didn't have until a year ago. The treatment is we actually put medication directly in the eye every 1 to 2 months. That's an ongoing process. But when I look at your retina and all of these scans and what we're doing, I think that you're an excellent candidate for that. And I'm fearful that if we don't do something, you're going to lose vision that we won't ever be able to recover. So I'm a little bit more straightforward with what's going on. What are the ramifications for not doing something? I'm not saying you have to do it, but I've set up a pretty good case for my patient why they should be considering the therapy.
Which typically I'm giving them the yes and no, why I'm referring you, what's the downside of if you don't go, what are we looking for future, which obviously is a very different conversation than we've had in the past with our geographic atrophy patients.
So I think that this is the probably the most important case to see. I've got a couple more that we'll just zip through because they are patients that I referred. This was someone coming in for a 6-month follow-up. They had already been diagnosed by me with GA years ago and was referred for clinical trial in the past. The left eye, you can see that the fovea is totally destroyed and then their count fingers vision. Their right eye, there's 20/50, but they had dropped significantly. And this is one where I look at that left eye and say, well, I know what that right eye is going to do in the next year or two. So clearly the left eye is probably beyond repair, but the right eye, we want to focus on doing possible therapy. Next slide, please. And this is showing that fundus autofluorescence again. Next slide. And a wide field raster along with an on-phos OCT showing large areas. And you look at say, how is this patient possibly 20/40, 20/50 in the right eye? They were, and we definitely want to consider therapy for a patient like this as well. Our final case, if we want to move forward, is a 73-year-old that I hadn't seen for a while. The patient hadn't been in for 18 months. I had diagnosed him with AMD before, and they told me, yeah, my vision's getting worse at night, and maybe I need cataract surgery. Vision's 20/25 ODOS. If we go to the next slide, we're going to see what happened is I actually had photos from way back in 2018 where I had diagnosed her with early AMD. And this is now where I can show this patient, look at what's going on here. We're starting to get these areas where you're missing tissue. It's called atrophy. We don't have a way to reverse it, but now we actually have a way to slow it down. And my fear is that if we don't do something here, this is going to progress and cause more vision problems. We've caught it just at the right time. We have therapy that can slow it down significantly. So hopefully this doesn't become a bigger issue for you. Next slide, please. So in, kind of summarizing everything, co-management of GA, setting expectations, we need to educate patients that it's a progressive, irreversible form of AMD. We have treatment options that can slow progression of GA, but don't reverse it. Vision may continue to worsen with or without treatment. Current treatment is administered by intravitreal injection every 1 to 2 months. Getting back to that maybe question before, when we asked, would you refer this patient? I think as you get more experience with this, depending on what sort of patient population you have, there's definitely things that are patient specific. When I'm talking about, are we actually going to send this patient for monthly or every other month injection when they're 20/20 or 20/25? We have to look at symptoms. Are they symptomatic? Certainly symptomatic patients are going to be more motivated. Age, I'm going to treat a 70-year-old differently than a 90-year-old because we know a rate of progression. Is the patient motivated to have treatment? Do they have other health issues or ocular comorbidities that we have to recognize? And then imaging specific things, progression rates, risk factors for progression. I think all of these things, as you get more experience in managing GA, you can have this more nuanced conversation. So when I say maybe, I really am looking at these other things and having a discussion. Does this make sense for the patient or not? Don't forget about referrals to low vision. And getting back to Dr. Kramer's point from the beginning, these patients still require primary eye care services. Do not just send them to the retina specialist and say, best of luck. I think they're going to be in great hands. Do you think the retina specialist is going to treat their dry eye or glaucoma? No way. We need to do those things, pre-appoint that patient for a follow-up in 6 to 12 months and make sure that you are controlling that patient experience.
They're definitely not going to refract them either. So